We live in an age in which it becomes increasingly difficult to stay healthy. This is not just because of the choices we make day by day, but it is also because the factors influencing our health are frequently found in factors that lie out of our control. As I have stated in my video on the male reproduction crisis, more and more evidence is found that the quality of our sperm has decreased in the past 50 years, as well as the sperm count, which dropped by over 50%. As Dr. Shana Twan, who participated in the meta-analysis which I showed in that video, convincingly shows in her 2020 book, Countdown, a portion of this decrease is attributable to factors which we cannot influence. For example, what our mothers ingest during their pregnancies or the amount of pesticides in the air which we inhale. Given these challenges, a new sort of movement has appeared which focuses on factors which we can control when it comes to our health. A new health-conscious generation has seemingly appeared as people hit the gym more frequently and closely watch and regulate their eating habits. The omnipresence of unhealthy foods and their abundance in our immediate surroundings demands that we, as rational individuals, are responsible for our own choices, influence, and change our natural desires in a way which will be beneficial for us in the long term. That's why I would suggest to call this new health-conscious movement long-termism, since long-term advantages are being traded in against short-term satisfaction. This movement has mostly focused on two pillars of modern living to influence the health of the individual. One of them is exercise and the other is diet. There are other factors which are important to consider when it comes down to health, but they are less focused upon since there is a growing consensus also in the medical community that primarily you influence your health via the amount and quality of your exercise and via the amount and quality of your diet. Now this focus is not new, nor did it originate with non-scientists' sudden interest in changing their habits. As always, this movement has taken its inspiration from science. And in science, one of the earliest proponents of one of the significant theories of the long-termism movements was Ancel Keys. Keys was a physiologist in the 20th century and is perhaps one of the most influential scientists of all time if we consider that his theories, among them especially the lipid hypothesis, are now considered consensus in the medical sciences. In this video I will provide an overview over this hypothesis and examine the difficult state that medical science, but especially nutritional science, is in at the moment. It will be seen that even apparently agreed upon results and theories in the field of medical science are more complex than it initially appears. This video is by no means a total review of all available studies concerning the lipid hypothesis, nor is it set out to be. But this video is providing a philosophical framework to examine a medical hypothesis and the way science is done in certain ways and provides information, but also to show what information it does not or cannot provide. First off, what is the lipid hypothesis? In very simple terms, the lipid hypothesis states that high levels of cholesterol and especially low-density lipoproteins, LDL cholesterol, leads to arteriosclerotic cardiovascular disease, ASCVD. More broadly, since saturated fats, defined for example by the American Heart Association as the fat in whole milk, cream, butter, cheese and meat, contain cholesterol and LDL, the lipid hypothesis states that a reduction in intake of saturated fats leads to a decrease in the prevalence of cardiovascular events, such as stroke or a myocardial infarction. Until today, almost all relevant institutions' guidelines recommend reducing intake of saturated fats, for example to levels below 10% of total energy intake by the Dietary Guidelines for Americans. based on the lipid hypothesis, and all of them believe the lipid hypothesis to be true, or, as one article stated, believe it to be universally recognized as a law. Probably the strongest evidence for this hypothesis came from a consensus statement by the European Arteriosclerosis Society Consensus Panel, published in 2017 in the European Heart Journal, probably the most prestigious journal for European studies concerning heart disease. Different kinds of studies were summarized which together encompassed over 2 million people and over 20 million person years, which is the amount of years participants in the study have been observed for. So for example, if one participant is observed in one study for 5 years, this would add 5 years to the total number of person years, and around 150,000 cardiovascular events. This consensus statement not only contained randomized trials in which participants are randomly allocated to a treatment group, in this case, for example, to the group in which lipid-lowering medication is being used, and the other in which this is not the case, to reduce possible confounding effects, which are effects which could influence the outcome, CVD, as well as the exposure, LDL. But it also used Mendelian randomization studies, which allow for causal mechanisms to be detected by including genetical effects and controlling for adjusting factors. As is stated in this publication, most publications that question the causal effect of LDL on the development of ASCVD tend to cite evidence from individual studies or a small group of highly selected studies, often without a quantitative synthesis of the presented evidence. Therefore, to avoid this type of selection bias, we have based our conclusions on the totality of evidence from separate meta-analysis of genetic studies, prospective epidemiologic studies, Mendelian randomization studies, and randomized clinical trials. This evidence base includes over 200 studies involving over 2 million participants with over 20 million person years of follow-up and more than 150,000 cardiovascular events. Together, these studies provide remarkably consistent and unequivocal evidence that LDL causes ASCVD. Not only this, but in 2023, the World Health Organization published a report on CVD in which high levels of low-density lipoprotein, LDL, is explicitly mentioned as a metabolic risk factor for cardiovascular disease in general. And we are not done. In David Spiegelhalter's excellent 2019 book, The Art of Statistics, he presents a systematic review that put together evidence concerning statins, which are lipid-lowering drugs, from 27 randomized trials, which I've explained earlier what that is, that encompassed 170,000 people at low CVD risk. This systematic review came out in 2012 in the crème de la crème medical journal, The Lancet. It was found that lowering LDL by 1 millimole per liter led to a 21% reduction in major vascular events. For Spiegelhalter personally, who takes a statin daily, this meant that his 13% risk of suffering a heart attack or stroke was reduced to a 7% risk, since his statin intake lowered his LDL by 2 millimole per liter. A 25% risk reduction for people with his characteristics and 1 millimole per liter means 0.75 times 0.75 is 0.56, so a 44% reduction of risk for him. Statins lower cholesterol, so it lowers LDL, and this leads to a reduction of cardiovascular events. We saw this effect now in several meta-analyses and systematic reviews. So it seems the case is closed, right? Ansel Keys was not only a physiologist, but he was also a study designer. One study he started, the Minnesota coronary experiment, which ran in the 1960s and 1970s, was a double-blind randomization study with 9,400 men and women, in which for one group the proportion of saturated fats in the diet was reduced from 18.5% to 9.2%, while raising the amount of polyunsaturated fats from 3.2% on average to 13.2%. This would be considered a heart-healthy diet based on Ansel Keys' theories. The patients were followed up on 3 years later, so the diet had a large time to show its effects. But what the researchers found was that the intervention group, now living with a heart-healthy diet, had no decreased risk of death at all, contrary to what has been expected. The results of the Minnesota coronary experiment have not been published until 2016. It was severely criticized by several proponents of the lipid hypothesis and declared unusable. But other studies in the meantime seem to support what has been found in the Minnesota coronary heart study. As medical doctor and New York Times publicist Aaron Carroll states in his 2017 book The Bad Food Bible, looking for more clues about the connections between alternatives to saturated fats and heart disease, researchers conducted a meta-analysis of all the studies that looked at this question. Even when they amassed all the evidence, they found that more people died on linoleic acid-rich diets, a polyunsaturated fat, like the heart-healthy one given to subjects in the Minnesota coronary experiment, than on baseline diets that contained more saturated fats, although the results were not statistically significant. What was significant, however, was the analysis conclusions about the health effects of saturated fats. Even when researchers twisted their models, they couldn't find any decreased risk of dying with diets lower in saturated fats. In New York Times, a Cochrane study in 2020, which is one of the most carefully designed studies that exist in the medical field, and which has to be designed in a very specific way to be allowed to be called a Cochrane review, using all available randomized clinical trials to assess the effect of reducing saturated fat intake and replacing it with carbohydrate, polyunsaturated, monosaturated fat, and/or protein on mortality and cardiovascular morbidity, found indeed that reducing saturated fat intake led to less cardiovascular events, but we found little or no effect of reducing saturated fat on all-cause mortality or cardiovascular mortality, both with grade moderate quality evidence, in around 55,000 people. There was little or no effect of reducing saturated fats on non-fatal myocardial infarction or CHD mortality, both low-quality evidence, but effects on total, fatal or non-fatal, myocardial infarction, stroke and CHD events were all unclear as the evidence was of very low quality. There was little or no effect on cancer mortality, cancer diagnosis, diabetes diagnosis, HDL cholesterol, serum triglycerides or blood pressure and small reductions in weight, serum total cholesterol, LDL cholesterol and BMI. There was no evidence of harmful effects of reducing saturated fat intakes. Another problem seems to be, as stated in Carroll's book, as well in a very recent 2022 systematic review published in the scientific journal Nutrients, that there is a lack of correlation between the dietary cholesterol, so the cholesterol taken up by the body with diet, and the cholesterol found in the blood. In the systematic review they write, "We confirm from the review of the literature on epidemiological data, meta-analysis, and clinical interventions, where dietary cholesterol challenges were utilized, that there is not a direct correlation between cholesterol intake and blood cholesterol. This lack of correlation is mainly due to the compensatory mechanisms exerted by the organism to manage excess dietary cholesterol, including decreases in cholesterol absorption and downregulation of cholesterol synthesis. A great number of epidemiological studies and meta-analyses indicate that dietary cholesterol is not associated with CVD risk, nor with elevated plasma cholesterol concentrations. Clinical interventions in the last 20 years demonstrate that challenges with dietary cholesterol do not increase the biomarkers associated with heart disease risk. Further, in the specific circumstances where X are the source of dietary cholesterol, an improvement in dyslipidemias is observed due to the formation of less atherogenic lipoproteins and changes in HDL associated with a more efficient reverse cholesterol transport. However, if the cholesterol sources are consumed with saturated and trans fats, as happens in the Western diet pattern, increases in plasma cholesterol may be observed. The most recent epidemiological data and clinical interventions, for the most part, continue to support the USDA 2015 dietary guidelines that remove the upper limit of dietary cholesterol. Carroll mentions that 70% of people are what we call hyperresponders to dietary cholesterol. This means that their blood cholesterol levels have almost no relationship to how much cholesterol they eat. So what does this all mean? Probably your head is turning hearing about all these studies, but this is exactly the point. It is not clear what the exact relationship is between cholesterol, saturated fats, and the health of your heart. As we've seen, high blood cholesterol levels are related to heart problems, but the correlation between your dietary cholesterol and your serum cholesterol is practically non-existent. Also, reducing saturated fats may not have that much of a positive effect as has previously been thought. And indeed, as has been proposed by Ansel Keys in his books, for example. But for decades, and still as is, this is promoted as a safe way to decrease the high prevalence of heart disease and obesity that seems like a plague wished upon our society. In this video, I wanted to show that even the cleanest and most thorough results promoted by institutions everywhere sometimes have to be subjected to scrutiny. And that even with a topic as clear as this, there is a lot of uncertainty surrounding the exact mechanisms that eventually lead to whether someone dies earlier or not. One should never forget that we all are individuals. Each of us moves differently, his inner workings are different, his eating habits are different. There is a case to be made that one has to start at the individual level to determine the exact right course of action if confronted with personal health problems. And this may differ from what has been found in many other studies and guidelines concerning the non-existent correct way of living.